Thank you, Mr. Chairman, for introducing me. I'll go through our study about the outcomes following kidney transplantation in patients with sickle cell disease, the impact of automated exchange blood transfusion. This is my agenda, starting with the introduction. And before going through the introduction, I'd like to ask you two simple questions. First, in sickle cell disease population reaching end-stage kidney disease, do you prefer to offer them transplantation or just to leave them on dialysis? That's the first question. The second question for you, if we decide to transplant the patient with these cells, would us prefer to put these patients on top-up transfusion? Transfusion is needed for the anemia, or for regular exchange blood transfusion to remove the cells and replace with new RBCs. This world map shows the relative prevalence of sickle cell disease in different areas of the world. And as you know, some areas of the world are endemic in sickle cell disease, particularly in sub-Saharan Africa, in India, Saudi Arabia, and the Mediterranean area in Turkey in particular. Here in Egypt, there are some red dots indicating low prevalence of sickle cell disease, and these patients tend to locate essentially in closed communities like Siwa oasis. In this study, there was about 800 sickle cell disease patients and 400 sickle beta thalassemia patients registered in the large hematology centers in Egypt in this study published in 2009. Patients with sickle cell disease are subject to a number of complications, of them chronic kidney disease due to sickle cell nephropathy, which progress ultimately to develop end-stage renal disease in about 4 to 12% of the patients. And in this French study, for example, renal failure developed in 11.6% of the patients. To the first question, whether to leave these patients on dialysis or to transplant them, simply, like in the general end-stage kidney disease population, renal transplantation provides survival advantage and should be systematically offered to all patients with sickle cell disease and end-stage kidney disease. However, after transplantation, these patients do worse than the general transplant population in terms of patient survival. However, the death census, the graft survival, were comparable between patients with sickle cell disease and those with other diagnoses. The second question now is, after transplantation, would we opt for regular exchange blood transfusion or just regular or as needed blood transfusion? In our study, we aimed in general to report the outcomes of patients with sickle cell disease undergoing kidney transplantation and also to analyze the impact of transfusion therapy policy in the pre or post-operative period. Our study was a retrospective multi-center study in 6 London renal units. Over a 20-year period, we identified 34 sickle cell disease patients who underwent kidney transplantation. And of these 34 patients, 20 underwent regular automated exchange blood transfusion, aiming at reducing sickle complications, maintaining hemoglobin above 9 all the time, and the hemoglobin S percentage below 30%. Now to our results. Overall, we had 34 patients. The majority of them had HBSS, the homozygous form phenotype, and just 5 patients had the hemoglobin SC genotype. The patients were followed up for a median of 4.5 years, and all of them didn't have preformed donor-specific antibodies before transplantation, so none of the patients was sensitized before transplantation, so none of the patients had preformed donor-specific antibodies. Overall, patient survival was inferior than the standard figures in the transplant population. At 1 year, 91% survived, at 5 years, 72%, and at 10 years, 33%. Regarding death census or the graft survival, it was also inferior to the general transplant population. At 1 year, 87% only, and at 5 years, 61%, at 10 years, 19%. Biopsy rejection occurred at high percentage of 38% of our patients. Let's now divide the cohort into the 2 groups, those with EBT versus no EBT. 20% underwent regular exchange blood transfusion versus 14% with no EBT, and 3 major differences exist between the 2 groups. First, the EBT group was a relatively recent group that was transplanted around 2012 versus 2005 in the no EBT group. And what does this mean? This implies that cyclosporine, there's some change in immunosuppressive protocol between the 2 groups. Cyclosporine was the main CNI, or was more commonly used in the second group, the no EBT group, while tacrolimus was the main CNI used in the first group, the EBT group. Tacrolimus, as we know, is a more potent CNI, and the post-transplant care was better in the more recent group, in the more recent era. So this may imply some confounding impact on the interpretation of our results. The second major difference is significantly those with EBT group received significantly much higher transfusion burden, 37 units on average per year, relative to, or in comparison to just 8 units in the no EBT group per year. And this was, This was reflected on lower hemoglobin S percentage at time of transplantation in the EBT group. However, we should take care of or we should be concerned about the risk of allosensitization in the group with a higher transfusion burden. Let's reflect now on the survival outcome data. From this Kaplan-Meier curve, we can see that the patient survival is significantly better in the first group, those with EBT. This group also achieved better graft survival. However, this didn't achieve statistical significance. And also, the first group, those who underwent regular exchange blood transfusion, could achieve higher eGFR at 1 and 5 years. When we come to compare the results in the two groups, the survival outcome in the two groups to the average UK data, we can see that the EBT group achieved the comparable patient and graft survival at 1 year. However, inferior 5-year and 10-year patient and graft survival relative to the UK average data. The second group with no EBT showed inferior graft and patient survival outcomes at all time points compared to the UK group and to the UK average data and compared to the first EBT group. Back to our concern about sensitization in the two groups of patients and graft-specific outcome data. From this graph, surprisingly, we can see that patients with no EBT had higher median calculated reaction frequency, higher incidence of rejection, and as expected, higher incidence of recurrent sickle cell disease. Both groups had comparable incidence of de novo donor-specific antibody post-transplant. These figures didn't achieve statistical significance, but were numerically different between the groups. The difference in the two groups in allosensitization. هي دقيقة واحدة بس. دقيقة واحدة خلاص بس. لو دقيقتين وهي دقيقة إن شاء الله هوقف في النص إن شاء الله. It was expected in the EBT group that these patients will be more allosensitized than the other group. However, these patients, our findings can be explained by the different time of transplantation and the more potent immunosuppressive protocol that may have protected the first group from being allosensitized. Mr. Chairman, now to conclude, overall, our cohort of sickle cell disease patients had higher rejection rates relative to the average data and inferior patient and graft survival. However, long-term EBT post-transplant is effective and safe, improving patient and graft outcomes with no increase in antibody formation, no increase in HLA sensitization, de novo donor-specific antibodies, or rejection. So now back to the second question, we can recommend now that post-transplant EBT programs should be adopted more widely when transplanting patients with sickle cell disease. And the optimal approach is probably, the best approach probably, to start the EBT immediately preoperatively. Before I finish, I'd like to acknowledge my co-authors and postdoctoral scholarship through which I could share in this work, and you for your attention. Thank you.